I do heart surgery almost every day, and I marvel at heart surgery almost every day. In fact, they can take someone and make them slip in the operative, saw through the middle of their breastbone, hold their heart, put them on the heart-lung machine, stop their heart, sew on their heart for half an hour, 45 minutes, restart their heart, take them off the heart-lung machine, and send them to the recovery room. And 3 or 4 hours later, they're sitting up in the bench. It was just phenomenal.
Time to embrace change and be about that life. This is Dr. Vass with the About That Life podcast, the podcast about life or living intentionally forever. We know that heart disease isn't something that only happens to the old, doesn't only happen to middle age, it happens across the spectrum. When we look internationally, diseases of cardiovascular issue occur more frequently than any other cause of morbidity and mortality across the world. Now, you can pick up heart disease at different stages. For me, I like to prevent it. I like to almost put myself out of work. You see, I said almost. But at the end, I really want people to understand that they can embody and embrace health through education, through engagement, and through other strategies that reduce disease. However, there are cases where either that patient comes to see a cardiologist too late, or that patient is born with conditions that need to be fixed through different ways. I know that plants are powerful, but they don't always reverse some of the things that we're born with. That said, today I have one of this country's leading experts in the field of, you guessed it, cardiothoracic surgery. That's right. He is healing with steel, as they say. And when it comes down to looking at his resume or CV, I mean, as I told him, it reads like a beautifully articulated book, right? And you can see in that it is always a point of service. So I want to introduce to some and present to others Dr. Antoine Keller. How are you, my friend?
Very fine, Doctor. Thank you so much for having me on your show. I am honored to be sitting behind you talking about things that mean so much to both of us.
Well, no, I'm glad that, and I know your schedule is busy. We have rescheduled. Now, some of it was me, some of it was him, but it is because we are doing healthcare. That's the reason. It's not because we didn't want to meet up and talk. It
Absolutely.
was just our schedules. But now that I got you, just get ready because I got questions. I'm just get ready. Just you. Hopefully you got some coffee. No, I won't hold you up. But let's just start with what made you pick cardiothoracic surgery. I'm always curious because I was there, but then after that 8-hour ASD repair with a VSD, that's when I knew that this probably wasn't a place for me. So why cardiothoracic surgery?
It's a very interesting question. I used to be a plastic surgeon when I was growing up. Living in Los Angeles when I was in college, I had the opportunity to participate in a program called the Pre-Medical Enrichment Program, or PrEP program at UCLA. And while I was there in the PrEP program, I interacted with a plastic surgeon and became enamored with surgery in general, certainly plastic surgery specifically. And so that's what I decided I wanted to be. And then I was accepted to Duke University Medical School for my medical school training. And while I was there, it was a very exciting time in cardiovascular surgery because they had just released a national study which compared balloon angioplasty to surgery. And there was a lot of action around cardiac surgery. And I had the good fortune to have a mentor named James Douglas, who was a young Black faculty member at Duke at the time. And we became friends, and he would get me up at 4 o'clock in the morning to go play racquetball. Then we'd make rounds at 6 o'clock in the morning and live in that life of a cardiac surgeon. And from that point, I was hooked. I got a chance to do surgery, research studies, and got a chance to learn a lot of engineering applications and techniques, and really became enamored with cardiovascular physiology. And everything I did after that was directed towards becoming a cardiac surgeon. So I had some really great influences growing up and circulating through was in medical school, and that really influenced my decision on going to cardiac surgery. And I think one of the most attractive things to me was cardiac surgery is the end of the line. They're the person that people call when there's nobody else to call. When everything else has been tried, and it's the last resort. And you have to be able to accommodate that situation. And that thrill was something that really interested me. So the fact that it was really pretty much a last-ditch effort for most people. I tell patients, their residents, or the students now, that we're meeting people in cardiac surgery on the second most important day of their lives, other than the day that they were done. Because it's the day that's going to determine the rest of their life. And it is quite a responsibility. And I appreciate the gravity of that responsibility. And I really enjoy being able to be that person for people.
You said so much in that statement to unpack. I mean, the first thing was, and hopefully the listeners pick up on this, you started your morning early, but you started with exercise and fitness, right? Because sometimes I think
Yes.
as healthcare providers, we can tell people about health, but then we don't live it. We don't embody what we tell people to do. But the fact that you all are up, cardiothoracic surgeons, 4 a.m. and doing racquetball, and then heading into work and enjoying that day. The other thing that resonates is the role of mentorship, right? Having somebody that, I do a program in elementary schools called Jump Right In. It's just, and it's no magic to it. I talk about heart health. We get the kids jumping around, but really so they can see me, because oftentimes it's hard for people to believe they can be it if they don't see it, right? And so for me,
Exactly.
it is showing people, hey, look, you can do this. You can be a cardiothoracic surgeon. You can navigate what that means. And the final thing, and even though people can pull from that, was how you described it as this is probably the first or second most important day of someone's life. And I can't tell you the number of patients that I come across either before they go into surgery or they're meeting me for the first time after, meaning they've transitioned cardiologists and they've had cardiac surgery. And our conversation is always the before and the after, right? And it's interesting that is the turning point, the juxtaposition of what their life had been. Again, not that I want my patients to be defined by their surgery, but it is such an important time and it changes your life. I mean, when people, describe what happens in an open heart, because people will hear the term open heart surgery and they think they know because I've been in. Describe it as best you can so people can visualize, not to scare anybody away. If you need surgery, get it. But I think it's important that people understand that this isn't just a pad, a couple of little clips here, then you go back. Talk about what that process.
Well, it's an interesting thing to consider, especially if you've never been faced with a major medical problem before in your life. And many of our patients are in the third nose or fourth nose, and they've really never been sick before. So to face the prospect of something that's going to change your life forever is really a daunting proposition. So usually things go really well. Most patients have better than a 95% chance of doing fine after their heart surgery and going on and living a long, happy life. And because of the fact that we have made so many advances in cardiovascular medicine and cardiac surgery over the last 50 years, people usually do well. But what goes on behind the scenes is really an amazing undertaking. And I do heart surgery almost every day. And I marvel at heart surgery almost every day. The fact that you can take someone and make them slump in the operating room, saw through the middle of their breastbone, hold their heart, put them on the heart-lung machine, stop their heart, sew on their heart for half an hour, 45 minutes, restart their heart, take them off the heart-lung machine, and send them to the recovery room. And 3 or 4 hours later, they're sitting up in the bed to me. It was just phenomenal to me. But that's what we do. And fortunately, we live in a time in which we have technology and medical professionals that have advanced the science far enough for us to be able to do that safely almost every time.
You said it so easily. Yeah, we saw, folks. I've seen, as a cardiologist, I get the imager, right? I get the pleasure of going in and doing what's called a transesophageal echo. It's where we do an ultrasound from inside the esophagus and look at the heart. And I've seen hundreds of cardiac surgery. Let me say it now, and I'm good. But it's never, just he described it as, I'm not saying I want heart surgery. Let me clarify. I'm just saying, you made it seem like such just a pleasant, and they go to a room and but the fact is, bro, it is a skill. It is how you know the true skill of a professional when they can make the complex things simple, right? And when I say a professional, I'm not just saying that because he's my friend, right? And in full disclosure, he's also my fraternity brother, and we focus on achievement and excellence. And looking at his CV, whether it's, going to Duke and going to UCLA and being named one of the top, cardiothoracic physicians in his area, being named one of the top physicians in the country. Those are things that he didn't mention. I'm mentioning them for him, and that's why that process of surgery is so smooth, right? Because as a professional and as an expert, it's not something that he goes into and he's concerned. He's certainly concerned about the patient's care, but as he said it, and he just slid it in there. He's also an innovator, right? When reading through his CV, he's done surgery on cutting edge research techniques, whether it's certain equipment or techniques. And that's what you want from your doctor, whether they're a cardiologist, a cardiothoracic surgeon, or anything, to be at the precipice of where research is. Because the one thing we know about medicine that's constant is change, right? And if you're not equipped, if you're ill-equipped to be flexible with that change, it's a challenge. Now, you mentioned it. Now, what things have changed in cardiothoracic surgery since you started 20, 30 years ago?
The first coronary bypass operation with a vein graft was performed in 1962 by the chairman of a surgery department at Duke. His name was David Sabastu, and he was also a mentor of mine. And he has really ushered in a paradigm transforming procedure by inventing this or performing this procedure, and the first person in 1962. So we've really only been doing cardiac surgery routinely since the 1970s. So it's not been very long, perhaps 50 years. And so a lot has changed because in those times, very little cardiovascular physiology and about how people recovered from heart surgery and other things to look out for and hazards and so forth. So much has transpired over the last 15 years. It's just been remarkable. And I will tell you, when I was thinking about being a cardiac surgeon at the time, this was in early 90s, I went to my advisor and I was like, I don't know if I really want to be a heart surgeon because people tell me that all I'm going to be doing is bypass operation after bypass operation after bypass operation, and I would get bored. And he said to me while we were having dinner, he said, well, I think you'll find that if you stick with it and if you persevere and don't listen to those people and enjoy doing what you do, then I think you'll find you'll be okay. And so about 20 years after, I was back in North Carolina having dinner with him again. And I brought up that conversation that we had had 20 years prior, about how people said that I was going to be doing the same thing every day, and about how my life now is anything but the same thing every day, because we do so many innovative things with catheter-based techniques and like as we were talking about before the show, clip, and we replace and repair heart valves with catheters and wires, and bypass operations are the least of what I do.
My
So
goodness.
it has been
Well,
a
that's because I do
remarkable
such a great
evolution.
job. That's why you do leave.
Well, of course. That goes without saying. Everybody already knows that. We're talking about things that are new now, Dr. Bass.
No, but it's interesting that most of the things I see aren't in, because I thought I would be doing that too. Just coronary artery disease. Oh, let me fix your cholesterol, do this. But now most of it is structural disease, right? It is things that
That's right.
and when we say structure, we're talking about in the way that, I simplify the heart in 3 areas where it can go wrong. You can have an electrical problem, right? That's EP in those folks, electrophysiology. You can have a blood flow problem. That's the artery, the bypass, or you can have a structural problem, which includes the valves, the tissue of the heart, the structures around the heart. So structural is what we're seeing now, where early on, before we really knew the impact of diet, exercise, lifestyle. And I think we knew, we just did, bypass was, I'm seeing people with abnormal stress tests, with chest pain and various things like that. But now what we're seeing is more of this structural push, also because structural has, in some cases, an earlier entry point, right? I send patients all the time to say, hey, you're a 30-something-year-old with valvular disease. We could do a quick fix now, and that way you don't have to get on any medicines and then do a more complete fix later, or we could do the complete fix now and tune you up later. There's so many different ways to, as we say, skin a cat, that even has changed as I make recommendations for patients. And I think that's where, as your CV reflects, being on the cutting edge,
Right.
being available to be flexible, be okay with change, understanding that, man, I can't do it the same way every time. And that's one thing that I encourage my patients to do, is to talk to their primary care doctors, to talk to their other specialists about other strategies to manage their disease. So, and I know you've made a push to really empower your patients to ask that next question. And so how do you go about it? How do you have that conversation with the patient who's thinking about getting, whether it's a valve replaced, bypass surgery, or any cardiothoracic surgery? What's your strategy with that?
Got it. Yeah, it's different for every patient, and you really have to kind of read where they are in their head with regard to facing this challenge. One of the first things that I almost always say, though, is it's appropriate to be a little apprehensive and nervous about it. Don't feel bad if you feel nervous, because even though we do this every day, it doesn't happen to you every day. So it's very important for me to take some time and wrap your brain around what's going to happen, because it is a life-changing experience for everybody. And so getting them to understand that it's okay to feel a little nervous about it is one of the biggest hurdles that we have to cross, because especially Black men, we have the Henry complex, where we have to be everything for everybody, and we're going to beat everything, and there's nothing that we can't handle. We can't let anybody see that we're upset about it or
Well, that's
nervous
true.
about
I
it.
never get nervous. I'm joking. Keep going. Go.
So really getting them to understand that it is a process, and that we are here to help them with the process and to give them the best chance of going to live a long, happy life, just as if they never had this problem at all. That's the first hurdle. The second hurdle is to think about the process of technical process of the surgery and what the recovery looks like. Because so many people hear open heart surgery and they think that they are going to be bedridden for 6 weeks, and they're not going to ever be able to work again. They're never going to be able to exercise again. And so I go through the process with them and tell them, the first morning after surgery, we're going to be up in the chair, on breakfast, eating yourself.
I bet they look at you like, no, how is what they're going. You just told me what you're going to do to me. How am I going to be doing that? That's I know their response.
Absolutely, it's true almost every time. But we try to get them to understand that by the time they go home, they'll be able to take care of themselves, fix breakfast, take a shower by themselves, assuming they did that for themselves before. And And so trying to get them to understand what the next 6 weeks or 6 months or from years looks like is the next thing. And then trying to get them to listen to their cardiologist and do the things the cardiologist tells them to do and don't do the things the cardiologist
Now, you're not
doesn't tell
just
them
saying
to
that
do,
because
you
I'm
know?
on the call, but yes, I like that
No,
point.
well, partly, yes, but but I think it's really important for people to understand that they have to know their part. And everybody knows the path, but not everybody walks the path. And smoking and out of control hypertension and diabetes. And, I tell the patients there are some things that we can control and some things that we can't control. You can't pick your parents. Your genetics are your genetics. It's not going to do much good for you, at least at this point in time, to worry about that. You can't pick your age, and usually you can't pick your sex. But you can decide to have an exercise program. You can decide to eat healthy. You can decide to take your diabetes medicine. We have great drugs for diabetes and high cholesterol and high blood pressure. You just have to make sure that you're focused on that.
Now you again, you give the book, and I love it. I was trying to write down stuff while you were talking because I'm gonna start messaging to my patients that way. And I know you do this for all your patients, but early on you talked about how African American men, how black men have that John Henry complex, and we want to do much. But on the flip side, we don't come to the doctor, and when we do, sometimes what we say doesn't get translated the way that we would think. And this is one of those areas of healthcare disparity. So I know where you practice, and looking at your CV, you've been a champion to try to, for lack of a better term, equal the playing field. So when I think about healthcare disparity, I think about people making a choice to do something or not. But I figure surgery, there's no, you need surgery, go to surgery. Are there health disparities in cardiothoracic surgery?
Well, one of the things that we have been very focused on over the last several years is aortic stenosis. And aortic stenosis is a blockage of the main valve inside your heart that keeps the blood moving in one direction when your heart pumps the blood to the rest of your body. Usually you have an aortic valve that's about the size of a quarter. When it gets to be about the size of a dime, usually people start to have problems with increase on shortness of breath and sometimes chest pain, sometimes not. Sometimes decreased exercise tolerance, or they just can't do what they used to be able to do. And it is sometimes attributed to getting older, but oftentimes it's not just getting older. It's that they have a problem with the heart valve called the aortic valve, which is structural heart disease, as you described earlier. And this is a really good model for studying healthcare disparities in underserved communities and in communities that are Hispanic or Black, because there are a couple of things going on. One is in clinical trials for medical devices where we can change these valves out with catheters and wires. We have about a 4% enrollment for African Americans, but African Americans make up 13% of the population. So we have a big discrepancy in the number of African Americans that are getting treated with this particular technology as opposed to a majority population. That's point number one. Why are Black people not getting transcatheter aortic valve replacement at the same rate as other patients are? The second thing is that Black patients are more likely to receive surgical aortic valve replacement than they are transcatheter aortic valve replacement. So transcatheter aortic valve replacement is a process where you come into the hospital, we put catheters in both groins, we replace your heart valve, and usually patients go home the very next day, back to their usual level of activity after a couple of weeks. For surgical aortic valve replacement, it is open, actually truly open heart surgery. We cut through your breastbone, open your heart, take the valve out, we put a new valve in, and then we'll recover you. Usually it takes about 4 or 5 weeks for people to recover. Then they have to ramp back up on their physical activity and usually go back to work after a couple of months. So these two processes are incredibly different. And Black folks don't get as much transcatheter therapy, and they have more surgical therapy, which is attended by a mortality risk that's twice as high for IMEs. So that's the first point. We have a big discrepancy or disparity in the number of people in the Black community that are having this technology and the number of people that are actually dying from having treatment for aortic stenosis. But if you look at the literature would indicate that Black people don't have as much aortic stenosis as the majority population does. And it's, in the literature, it's about half as much. But it's hard to reconcile this fact because if you look at the rates of cardiovascular disease death in the United States, Black patients have a much higher risk of cardiovascular death than do white patients or any other racial or ethnic group. So on the one hand, you're saying Black patients have a higher risk of some cardiovascular mortality. But on the other hand, you're saying that their structural heart disease risk is half as much. And you can't reconcile those two things. So one of the things that we have been working on is trying to understand how access to healthcare and bias come into play with aortic stenosis. And it's a really interesting model because we have been going out into the community with technology that can diagnose heart murmurs and aortic stenosis just from listening to someone's heart and using computer generated AI to be able to determine whether they have a high likelihood to have structural heart disease or not. And we're finding a couple of things that have not been reported in the literature in any scale because of the fact that these are people who don't go to the doctor. They wouldn't normally go to the doctor. They're not in the system. And the way we determine our prediction or predict how many people in a certain community should have these problems is we take incidence data, which means these are people that have already been treated. And we pair that with census data and we retrospectively try to predict how many people should have this problem. Well, the first part of my explanation, which is a little bit long, but I hope you give me 5 more minutes.
You got time. I told you what you see me doing. I'm jotting down notes. This gonna make me sound real smart in our next meeting. So I'm in class right now. So keep going.
Okay. So if you only look at incidence, but you admit that these people are not going to the doctor, then the incidence number has an error, which I believe is unreasonable. And if you retrospectively use that bad data to predict what the prevalence is, then you're going to have bad data coming out too. So we went to the community. We took this technology to people in the community, and we found that of patients or people in the community over age 60, 1 out of every 4 of them had a heart murmur that was significant.
That's 25%. Hold on now.
That's 25%. And the most interesting thing about it is 55% of those people that were found to have murmurs did not have a cardiologist or a healthcare professional who had been listening to their heart on a regular basis. So this is a significant proportion of the Black population and the socioeconomically challenged population that aren't in the system, that we would never know whether they had these problems or not. Many of them will die without ever having known that they had structural heart disease. One of the other things that we learned is that the patients or people in the community that we went to screen at 3 screening events using this AI technology, we give people something with no strings attached. We don't take their name, their phone number, their social security number. Of the patients who come to see us at the screening programs, 90% of them are women. And so we really have uncovered a problem. We knew we had a problem,
Not like that.
We didn't know what the magnitude of the problem was.
Because that doesn't fit with, well, I'll say it is somewhat inconsistent with what the broader messaging is about heart disease in underserved or African-American communities specifically, right? It is framed. So you all have identified that, hey, the rates of structural disease are probably higher, right? In our data set was 25%, 1 in 4 people, meaning that's astounding. Now, when you extrapolate that out, it might be less, but I'm sure it's more than what is currently reported, which, hey, African Americans don't have a problem with structural heart disease. Now, I may have a selection bias because many of the patients that see me look like me, right? And so, and I see a fair amount of aortic stenosis, a fair amount of, mitral disease. I see a fair, and it's interesting because from my framework, because, and I guess that is my bias, right? I give everybody a clean slate until I put the stethoscope on. And once I put the stethoscope on, I allow it to write what happens next. And now why is it that there's an access issue to people not to get care? Is it that because physicians potentially as a whole have an idea that, well, I don't think this occurs with any frequency in this community, so I'm not going to do these next steps. So why? And I know we're in the bias, but this matches with those social determinants of health, and you talked about access. What would you say are the things, because people like you and me, we kind of know the game. We know what direction we're going to go, but how do we champion policy? So I guess one question is, why? Why does this happen? And could we develop policy to maybe curve some of these gaps in care? Let's say it that way.
Yeah, we could spend about 3 hours talking about all of those things, but I'm going to give you a nutshell, which really is, I think that one of the most important things for people like me and you is to find solutions, not only identify disparities when they occur, but also to propose solutions to try to figure out how we can rectify that situation and promote health equity in underserved communities. And so the first question I get when I tell people what I just told you is, well, if 1 in 4 of them have murmurs, most of them are probably going to be clinically insignificant. And that people probably just need to be followed along just to see when they get worse. And this is true. But if there's no one to follow them along, then we're still stuck where we were before. And that 1 in 4 number really is still significant to me. And the second thing is that there is a very nice study done by a doctor named Bodegard, and he showed that he had follow-up for 10 years of these patients who were found to have heart murmurs by regular auscultation without digital enhancement and without artificial intelligence. And even the ones who had grade 1 or grade 2, which are very low-grade murmurs that some people might not even be able to hear, these people over the ensuing 10 years had a 5 times greater risk of having to have surgery for aortic valve disease. And if you had a grade 3 or grade 4 murmur, then you had an 89 times greater risk. So even subtle murmurs that may not be able to be appreciated by someone that's not used to listening to people's hearts all the time can be significant, and people need to be followed by someone who has some expertise in this area. Now, you're talking about bias and policy. And bias and policy are really important concepts to wrap your head around for cardiovascular disease, because first, if people aren't going to the doctor, or they don't have access to a doctor, or they don't have access to culturally sensitive information about cardiovascular disease, or they don't have people who look like them in their community that are accessible to them, then they're not going to get heart care or heart disease care. And so people often ask me, you can have white doctors in black communities that give the same care as black doctors in black communities. So why don't we just recruit people to come to the community and solve all the problems?
That's an option.
And so when they do that, then I tell them a little story. I did some time in California, so I like the entertainment industry. My sister has been working in the entertainment industry. I heard someone tell a story recently that really kind of resonated with me. And so there are 2 movies, Goodfellas and Schindler's List, both fantastic movies. And Goodfellas was directed by Martin Scorsese, and Schindler's List was directed by Steven Spielberg. They both won numerous awards, and everybody knows about those movies, at least most people do. So if you would have been asked Spielberg to direct Goodfellas and Scorsese to direct Schindler's List, you wouldn't have had the same movies, because Scorsese would not have been able to pay as much attention to the nuances of Jewish culture, and 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 Spielberg would not have been able to understand Italian American culture and convey it in such a way that it resonated with people even in those
You're
communities.
preaching now.
And so how could you expect a white doctor to understand cultural pressures and um, food insecurity pressures and all the things culturally and politically and socially that people in those racial and ethnic communities have to deal with, as well, because they don't have the same shared lived experiences? It's amazing. And it's not that these people are bad doctors. They obviously, a lot of them go to Harvard and Yale and RT and places like
no, definitely.
and do, but it's just that they don't have a really good understanding of the fact that sometimes people have to take 4 or 5 buses to get to the doctor because there's no doctor in their neighborhood, or they have to go 4 or 5 miles to get groceries where they can find fresh fruits and vegetables when they don't have a car or reliable transportation, or they don't have someone to watch their kids for them to go spend a day in the doctor's office, because even though we do our best, sometimes the wait times tend to be long, and they can't take that much time off work because they're living check to check to feed their family. So all of these things have an impact and exert pressure on people in underserved communities that inhibit their matriculation through the clinical care pathway. So these kinds of biases, whether they're political, structural, institutional, geographical, all of these things it is a very complex milieu, but they all impact how people have access to healthcare. And so policy, what can we do to influence healthcare?
You knew I was going to ask that tough
in order to
question.
be able
'Cause
to,
you got a big brain. So I said, let me throw this one. I typically don't ask people to drive, but I want to hear it. And if it looks like I am writing, because I just love how you articulated the entertainment industry and what we expect from producers and what they put out, and how we feel like, as you said, it resonates because it's familiar to them. And in trying to juxtapose that in the space of saying, well, let's take a doctor that's unfamiliar, put him in a space, have him connect. And now let's, like you said, let's break down, how do we develop policy to overcome bias and what may be ingrained in those systems?
Yeah, so this is a very important issue, obviously, but I think it's one that is as deep as it is complex, because if you look at the surface, Black patients, for instance, with aortic stenosis have the exact same clinical outcome expectation as white patients do. There's no difference in mortality and morbidity when they get this transcatheter therapy. But Black patients more frequently get surgical therapy, and even though they have the same outcome from transcatheter therapy, we cannot really make this comparison where Black patients and white patients have the same expectation. And so some colleagues and I wrote a paper, and Jack advances about 3 months ago, which looked at the residential segregation index. And we looked at Black patients in Black communities having an expectation of treatment for their aortic valve replacement, and they don't do as well as white patients in white communities. And Black patients in white communities don't do as well either. So it's really interesting to understand that if we just look at outcomes, we're missing a significant proportion of the picture. And so with policy, when people make policy, and you may know a lot more about this than I do, I'm just a heart surgeon. And I'm a good heart surgeon, but I'm not a very good
Hey, that's
policy
why I asked you.
analyst.
You try to be. That's why I
So,
asked you. I said I'm gonna write down his policy options, and then I'm gonna push those. I'm gonna give you credit, of course, but I'm gonna. That's why I asked. I
yeah,
typically don't ask policy questions, but after reading
totally.
your CV and having to take notes and getting, I hope you don't ask too. I mean, you got over 12 pages of research stuff. I said he gotta have a option. He gotta have a choice. He gonna give us some options. So keep going. I told you. I'm writing, taking notes.
Well, I think just as we talked about before, if you put bad information in, you're going to get bad information out. And so policy is the same way. In policy, many times we look at historical trends and data about what's going on in our nation as a whole. There's certainly regional differences that have an impact on policy. For the most part, we look at clinical data and we make judgments about what to do based upon that data. We know that that data is not right. And we know that there are some major errors and assumptions that you have to make when you're trying to attribute national statistics to underserved communities. And so, unless we go into the community and publish data on people in our community in an honest, unbiased way, we will never have the information that we need to appropriately care for these people from a policy perspective. Does that
That
make
makes
sense?
perfect sense. I mean, it is, and I hate to say buzzwords, but everything you said is linked. Like you said, the first thing is if we assume that there isn't a problem, that's that bad data in, and then the policy to say is, well, there's nothing to fix, so we don't need to have policy to fix it. Then the next thing that you tackle, which, like you said, this is a 3, 4, 5, 6 hour day conference. Next thing you tackle was, well, let's look at the provider, right? Because we talked about policy. Well, let's get to the provider level and see if we can install providers that are patient-centric. Like you said, good doctors, but don't connect with the patient, right? There's this disconnect that occurs, and some of it is in communication. Some of it is understanding access. In San Antonio, we have this thing where the city looked at zip codes, right? They looked at zip codes and said, okay, this zip code has 15 grocery stores. Like I can literally walk up the street and it's a grocery store 2 times the size. Whereas if you travel just 10 miles down the road and go to the south or to the east, guess what? You got to get on 2 buses. You got to do it. Now the city used that to drive policy to say, hey, grocery stores, you got to be proportional. Now they didn't force them, but they said we do think you should. And I think the grocery stores responded, but it's just that access issue that occurs. And so then you say, well, even at the patient level, their expectations are the same. I just want to feel good. I don't want to die sooner than I need to, and I want to make sure that so the patient's expectations are the same, but it is as we go up that chain, it is this constructive bias. And what I want you to do, and I know we've been talking a while, I'm just, like I said, this is great. I told you, got notes. How would you define bias? Because, and we're talking about implicit bias, right? But how would you define bias in that sense? And then I want you to tell me about a program that both you and I are working on to do our part to try to demystify understanding, recognition, and elimination of bias in healthcare spaces.
Yeah, it is. Bias is a very complicated thing because most people don't feel like they have any biases. But you and I know, after having gone through implicit bias training and been intentional about understanding what our personal biases are, we all have biases. And, as they say in some medical fields dealing with addiction, the first part is admitting that you have a problem. The first part is understanding that it's okay. You don't have to be critical of yourself because you have biases, because everybody has them, but understanding how to recognize them and understanding to be sensitive and empathetic to your biases and other people's biases is the first part of overcoming. is understanding them. So, as you mentioned, we have been part of a very innovative program that has been put on by the American College of Cardiology called Implicit Bias Training the Trainer, which we get together and try to figure out how we can train people who work in healthcare environments and certainly other environments too, how to be sensitive to their own biases and how to be sensitive to other people's biases. And it really has been an enlightening experience for me. You have a lot more experience in dealing with people and their biases on a professional level by virtue of your occupation and where you work and what kinds of things you've been involved in. And so it has been a really unbelievable educational experience for me. I'm really proud to be a part of it and really honored to be able to learn from all of it.
No, I mean, and when I saw you in there and they announced you as a surgeon, I had to take, no, this is a cardiology, but just hearing your work on aortic stenosis and understanding kind of where in the country you are, which I love Louisiana and I love definitely visiting, but understanding some of the data that comes out of Tulane and where they talk about how just one street over, this is what the life expectancy is versus 2 streets, we expect this. And like you said, patients have the same expectation. It is our environments that unfortunately changes that for some of them. Well, this has been a wonderful discussion. We are going to be working on another program together in about 10 days. So I may have to give you a call as we prepare for that about bias. And that one, instead of training the trainer, we're going to move it around and empower patients, right? We're going to teach patients how to decrease or recognize, as you said, I like that, recognize it and then try to demystify it. Try to almost help your provider help you, right? The best way to help yourself is to help somebody help you. And we're going to empower our brothers, the brothers of Kappa Alpha Psi on the 7th of February, where we're just going to have a sit down and we're going to go through it with them. And we're going to talk about biases in healthcare, specifically cardiovascular care. We're going to talk about that in just an open forum and help them work through it. And I'm always enjoy having Dr. Keller and sitting down and talk with him. Well, if you had 3 things that people could take away from this, you've already given us, like I said, if they want the rest, they're going to have to listen to the master class. I'm going to need the transcript. But 3 things, 3 nuggets that they can take away from a CT surgeon's perspective, from a biased professional who understands how to recognize, and from a researcher who looks at the data and knows the epidemiology behind all these things. What would it be, my friend?
Number 1 is take control of your wellness. You are your biggest advocate. When you go to the doctor, ask questions. If you go to a doctor that doesn't like to answer your questions, you need a new doctor. Take care of yourself. Take care of your wellness. Be engaged in your health care. Make sure that you do the things that your cardiologist tells you to do. Don't do the things he tells you not to do. But that really is, I think, the biggest take-home message for me is wellness is a full-time job, 365 days in the year. And if you can give yourself the best chance to live a long, happy life, you won't regret it. The second thing is, it is important to get wide-ranging perspectives when you're faced with some sort of a life-changing decision. Don't hesitate to get a second opinion or to ask other healthcare professionals that are in other disciplines what they think about it. We have this thing in structural heart disease called the heart team. And it is a concept that has been put forward by our respective societies, the surgeons and the cardiologists. And the sole intention of it is to give the patients the best form or mode of therapy for what they have individually, not to try to make the technology match the patient. And so we have cardiologists and surgeons, sometimes we have psychiatrists and family practice doctors all working together to try to reason with patients to understand where they are in their lives, what their lifestyles are like, and what's the best form of therapy for them. So get a lot of different opinions. That's the best way to reduce bias and to also improve for long-term health and wellness for the rest of your life. And with regard to policy, the only way to find out where we are in underserved communities is to have good data. So if you hear that Dr. Bass is coming from your community, go and support him. Support his programs, support his research efforts, go talk to him about bias, because he's making an effort to come into a community that not very many people come to, certainly not many Black or brown people. So you have to take advantage of whatever. Those are my two things.
First off, thank you for that vote of confidence coming from you. Really means a lot. No, and you're far too humble. Is what I tell my kids. It's pathologic humility almost, because you have done so great, spoken so well, given me some ideas. But those three nuggets, I mean, I know we were saying for other people, but I'm gonna take them, right? So the first one was wellness is a full-time job, right? You know, because I can tell you, illness don't take a day off. Illness don't say, you know what? I'm not gonna make you feel poorly on this day. So wellness is a full-time job. Secondly, perspective matters. So having a second, third, fourth opinion about various things. And you talked about the heart team. There's a patient, multi-vessel disease, everything you can think of. And I was just honored that they said, hey, look, we know you don't, we just want you to talk to him. And again, he looks like you and me. And he initially told him no, because the Lord's gonna, in which I believe in faith, but God also gives us wisdom. And so as we work through what that means for him, we're able to understand why it was a no. And then finally, when it comes to policy, understanding that policy isn't easy, right? If we could think of a single fix to roll out for everybody, we would probably do it, right? But it is participating. Policy requires participation, because if you don't have a seat at the table, as my dad used to say, guess what? You're on the menu. That's what that means. If you're not sitting at the table, you're on the menu. But as we close out this episode of the About That Life podcast, the one thing that Dr. Keller's message has told us is to be an advocate. Whether you're a provider, whether you're a policymaker, whether you're a patient, is to advocate for not only your own health, but the health of your community and the people that you care for. He went through strategies, tips, tricks, whatever you name it, to improve ways that you can engage as a provider, but also how you can prepare as a patient. All of these skills bundle up into a package that helps you try to identify, reduce, and eliminate bias as it impacts how you deliver care and how you receive it. Understand that wellness and health is a full-time job. Don't take a day off, because disease won't. I want to thank you all for joining us today, and remember to be about that life. We truly hope you enjoyed today's episode. If you did, share it with a friend, leave a comment, and certainly join us for our next episode of the About That Life podcast.